Okay, sister. Dr. Bach? Dr. Bach, can you hear me?
Hi. All right. Can you hear me?
Yes, clearly.
Okay. This is a last session. Would be last cases from the Assam Medical Center. So, as usual, I'd like to do last cases with our family. Dr. An, Dr. Lee, and Dr. Bach he's coming. And this is a little bit complex bifurcation disease. So we're gonna introduce from the patient history first. Dr. An, please.
Okay. This is a 72-year-old gentleman visited our patient clinic with chest pain during climbing. So initially he underwent a CT, showed some abnormality, and we checked the coronary angiogram. Next. So hypertension history and smoker. Next. So echocardiogram treadmill thallium was not done. So coronary angiogram show like this. Very tight stenosis with LAD and diagonal bifurcation.
Right. Can you see this, Andrew?
Yes, we can see clearly.
Okay. So we placed the two wires, diagonal branches, the first big diagonal and LED 2, right? And then actually this is very true bifurcation disease, median class 111. And so we have to decide this is optional T-stent or two-stent technique from the beginning. So Dr. Rubad over there, right? What do you think? Would you discuss about that?
I think first that this diagonal is of importance because this is the main diagonal, maybe single one, small one distally. So this is the kind of vessel we can call a relevant, probably clinically relevant vessel. So I think it's not very clearly it's not a simple protection. So we have to decide how to begin. In my place, I will certainly do a provisional, but with a chance to have a second stenting after the main vessel stenting.
Akasaka?
Yes.
Yes.
It's a very complex region. So, and also the diagonal is very significant, and the angle from the LAD is very narrow. So there are some risk of a side branch occlusion. So as you said, the T-stent might be the one of the option to treat in this case. But by imaging, we can further investigate the risk of the side branch occlusion. Yeah.
So you want to do optional T-stent and two-stent?
In this case, I try to select the two-stent. Yeah.
Selected the two-stent. Okay. Any other suggestion, Dr. Singh?
It's quite a complicated case. I'm not convinced that the diagonal is actually small. Is this a 7 French or an 8 French catheter?
8 French.
Okay, so the diagonal is rather small. What I would actually do, and there's a discrepancy between the proximal LED and the mid LED as well. So what I would rather actually balloon both, look at the flow, and I'm opting to go actually more for a provisional option first, and then to look at the flow after the diagonal flow after the initial stenting.
Oh, Dr. Wu, any other suggestion?
This is actually this difficult decision because sizable diagonal, but the territory. What do you think? The territory comprise 5% or more for the whole LV territory. If that more than 5 or maybe between 5 to 10%, probably I would considering two-stent strategy. But the two-stent strategy now probably you will be argue with Dr. Chen from China regarding what kind of method. He said that DK crush would be better, and Asan's experience saying might be as simple as possible, or just you routinely just do a regular crush but for this kind of lesion, or maybe French experience, maybe just tap provisional, then is to see the diagonal, then probably tap for the final. So this is several ways to go. But I probably like to see actually the IVUS showing that's what the size, and we can probably make a decision.
Okay, great. So it's quite, similar way of thinking for the tight radial diagonal stenosis. It's truly digital segment of a diagonal branch is not so small. Actually, it's by angiographically around 2.5 something. And particularly this striation, so according to the current data, so using the second generation of drilled stent, actually we didn't find any difference in terms of optional T-stent technique, simply stent crossover, and two-stent technique. Even we used the two-stent from the beginning, the clinical outcome concern is almost same. So no difference at all. So the reason why the concept is getting better, the DS itself is more efficient, not too much concern about the stent thrombosis concern. And so two stent procedures, if there were true bifurcation disease, actually we don't hesitate to do select the two stents. The issue is actually the size-wise, the diagonal branch is 2 or 2.5, relatively small one. So I want to show that we, to be honest, we have quite enough time. I was forced and measure the
size of diagonal.
Yeah, diagonal size first and LED size.
Yes.
And then, what do you think? The balloon inflate and nitroglycerin, so wait somewhat, 1 or 2 minutes.
And then
Maybe there are some changes in terms of reference vessel diameter. And so we, to be honest, is before the IVUS, is we're going to do the balloon, dilation first. However, I want to show what's happened. I believe that. And so this is IVUS. Okay. Different. So diagonal branch first.
So this is the pictures already do a balloon dilatation with simultaneous kissing?
No.
Not yet, okay.
No, not yet. Yeah, this is very freshy, non-touches. Okay. All right. This is IVUS caster. A little bit difficult to pass. However, okay, it works. We have already administered nitroglycerin. And so basically, okay, from here, far distal diagonal branches here. Okay, right now, pull back. Size-wise, almost 3, right?
Yes, almost 3.
More than 2.5, 2.7 something, right? And the pull back.
Yes, now pull back.
Getting smaller. Did you think so?
Small negative remodeling.
Small degree of negative remodeling, some plaque, diffuse disease. Almost on the 3-0.
Yeah, 3.
All right, big vessel. We cannot realize, if we don't have, IVUS concept, there's a very occipital part, truly disease, some superficial calcium. This is LED. Big vessel, right? Then we expected 1, 2, 3, 4, more than 4 proximal. Ooh. 2 hours and 2 o'clock, 3, 4, 5, almost big vessel proximally. Minimal disease, almost 5 to 6 proximal LED. And you want to see that? Okay. Very proximal part, minimal disease. However, I'd like to quit the epsilon from diagonal branches. And then I want to show what's happened in the LED segment 2. Let's keep there. Okay, light on. 그리고 꺾여가지고 프록스 여기 목이. 오케이. ready? Okay. Stent distal, region distal, minimal plaque, media to media is almost 354.
Yeah.
Big vessel. Superficial calcium. Some disease, however, not too much significant. Vessel size was 4O. Eccentric plaque, minimal. Superficial calciums.
Rupture.
Okay, close to the diagonal branches.
Diagonal branch from one of them.
All right. Did you pass? I
Yes.
did. I pick up.
This is proximal LED.
Mm-hmm.
For the minimal plug. Internal diameter is almost 3.5. Very mild disease.
Reference vessel diameter is very
Four,
big one.
yeah.
So 4, more than 4, almost 5.
Here
This is
a
very proximal.
proximal, yes.
All right, when I see that, still minimal lumen diameter is preserved, the main
Yes.
here. Big vessel. Still some superficial calcium, however, not pretty much disease over there. Okay, so I want to pull the device out. Okay, take a picture again. This is ready, and that is diagonal. So, okay. After, okay, would you show us again LED round, so just bifurcating areas? I want to miss the reason why the region segment is very short.
Bifurcation 나오는데.
Is this LED round? Okay, go ahead. Oh, that one,
Yes.
culprit, right?
1 p.m. Oh, 1 p.m.
Pretty much plaque.
1 o'clock. Here is a diagonal branch.
And then we have already proximal part, right?
Yeah.
Mainly soft plaque
Yes,
for LED, and we've learned quite, different findings. Is diagonal branch is relatively, big ones
one.
rather than we expected. Would you show us again diagonal long, the very austere part? Diagonal.
Diagonal long, please.
SJ, because Akasakas here is the expert of IBIS and OCT, I want to ask him regarding the opinion regarding OCT-guided PCI and IBIS-guided PCI. In this case, what do you think?
Right.
Which one is better?
Yeah, in this case, the region is very tight. If we try to do the OCT, we need a pre-dilatation, right? But so at that time, IBIS is much more convenient. And in this case, I'm wondering that the plaque is the opposite compared with an ordinary case, right? In LED, the plaque is in the diagonal side. So if we put the simple stent in LED, I'm afraid the risk of a side branch occlusion. And as Dr. Park said, the diagonal branch is enough big, so we have to do something in the diagonal branch. Yeah.
Agree. So, all right, so we've learned, anyway, there are critical stenosis of diagonal austere part. There's some, superficial calcium too, size-wise almost a 27530. And so we're going to do the 2.5 non-compliant balloon inflation for diagonal branches. And we're going to deploy the 275. What about the region lengths? Could you measure that? Show this, the diagonal branches.
Vision length
13. All right, here we are. Test, please. Okay, I think here we are. Just a minute. I want to pull the balloon out. Okay, inflate. Okay, deflate. 2.5 non-compliant, right? When are we going to do a little bit high pressure? 16. All right. 18. All right, 2.5. Deflate. Size-wise, LAD is almost, what is it, 4.0, right?
yes.
Reference vessel diameter 4.1, so we're going to use, I would like to choose the 35, non-compliant, 20. Okay, I want to keep the balloon on the LAD and use the 275 Stent for the diagonal branch first. Okay, picture. Okay, not too much different. Maybe some dissection, something. So I try the 275,
Yes.
18.
Yes.
Okay,
18 giants for diagonal.
yep.
So what kind of technique you are going to have? Two Stent techniques.
All right.
Crush
Kind
or
of a mini crush.
mini crush? Okay.
So before that, to simplify, I don't want to two Stent, something like, and so try the balloon crush first, and then, okay, another Stent for the LED. So this is a 275, quite a matched size with a diagonal here, and then,
35, 20.
okay, 35, 20, non-compliant balloon, please.
Because for me and Dr. Lubo, we are transradial guys. Doing this technique, probably 6 French would be enough
Right.
for transradial. Maybe we can do Shishley's 7 French from the radio. But I see you are still continue using 8 French from femoral. So,
Right.
but I consider 7 French big guiding should be enough for this kind of
Okay.
technique.
Okay, agree. So, however, in sometimes we can meet some, unexpected situation for bifurcation intervention, limb main intervention. So I still prefer the bigger guiders. Okay, test please. I think it's okay. Inflate for diagonal branches. The match is with the balloon and 275. What is nominal?
10.
Okay, quite enough. Deflate. And then I want to pull the balloon out a little bit. I want to damage it to the distal part of the stent here. Okay, inflate. What about 16? 16 is quite enough. Okay, deflate. So the reason why is I really, prefer the mini crush is quite simple, rather than the other technique. Just deploy the stent. Test, please. Okay, inflate. LED to tight stenosis here. Deflate. And wire in and balloon in. Okay, inflate. Cover that. Okay, clear.
16.
35.
Yes.
Okay, deflate. Okay, just we have to confirm. One more. All right, I would like to crush the diagonal ostium. Okay,
16.
16. Okay, great. So size, reference vessel size-wise is almost 4.0. However, I would like to try the 3.5 and make some part at 4, some part is 3.8 something, right? So, okay, take a picture here. Yeah, there are some haziness, however, I think it's okay. Very soft plaque, maybe related with some thrombus containing, I think so. So,
Would you like to change the
okay,
projection?
right now. The this view,
Yes.
we have already picked up the test, please. I said, make a separate, very difficult to separate with a radiant diagonal here. Test, please. What do you think? Better?
Yes.
Sometimes true, very high cranial and aerial view separate with a proximal LED.
What about AP, somewhat just shadow aerial, AP cranial?
Slight LAO with cranial will be good.
AP cranial, you do Monday? However, it's good. We know that where a big diagonal branch over there, and so what is the lesion length? 28, I think it's okay,
Yes.
right? 28.
28, 3.25.
35. Okay. We're very, comfortable to do the procedures. Just stand it for the diagonal branches, and separately crush, balloon crush, and softly another stent, cover the main branches, and then we're gonna finalize the final kissing balloon inflations. In almost all cases, we have to consider, okay, test please. Okay, test. I think it's okay. What is it? Go.
Change to
Okay, how
move
much?
to the,
I want to check
move
that.
to the spider.
Okay. Okay, clear. Test. Which actually covers. Okay, are you? Okay, just a minute. I will take it. Okay, contact please. Not too much.
Okay.
1 millimeter. Pull the stent out. Test.
Test it.
Okay. What is it?
Good.
It's okay. Good.
Yeah.
Inflate.
10.
Okay. 10, 12,
12.
3.6, 12, 13, 14. Why not 16?
16.
The reason why the vessel size itself is a pretty big one, we don't too much concern. Okay. Deflate. Pull the balloon out a little bit. Proximal part.
It's 4 or at least 3.8.
All right, great. Inflate. To 18, 20. What about the 20? 3.5. Okay, deflate. Balloon inflation for the proximal part of LED. Some balloon damage over there. So, however, we're going to see that what's happened. Okay. Test, please. Okay. Full shot.
Oh, nice.
And geographically is almost perfect, right? I don't want more procedure for that. However, okay, we're gonna do another wire, decrossing. Others?
Ready
Okay.
for crossing the.
All right. So if you want to see the proximal part of stent, actually there are some size discrepancy. So if it is
Kind
there
of
is
half.
some malposition,
Yes.
we need a bigger balloon.
Yeah.
inflation and kind of a simultaneous path proximal optimization too. And we show that just the distal. Okay, this is normal looking area. All right,
Yes.
good. I like it. Distal.
Yes, this
Can you
Here.
read this one? Okay, read.
here. So distal landing is perfect.
I like it. I like it. All right. Full lesion coverage,
Yeah. Very expanded stent. and
normal
less-
position.
yeah.
And actually stent diameter is almost 4, right? Stent area is almost 12 millimeter square something. That's big enough. Right. I don't want to, okay. That would be diagonal branches.
Yes. 1 o'clock.
1 o'clock.
Yeah.
We use the 3.5 stent.
Yeah.
However, minimal stent area is almost 4,
Yes,
right? We're
right.
going to do the 3.8 something. Well, opposed stent to the lesion,
1 or 2.
I think it's perfect,
Yeah.
right? Almost perfect. So we don't need any, more dilation for LAD
Yeah.
part.
Yeah.
However, we're going to try the wire diagonal branches. What wire? What kind of wire do you prefer? Lubat and Dr. Wu. So it is typical, mini crochet.
I'm not for the wire. I'm not doing practicing this kind of technique. So now you have to go through this wall of the main stent and also the wall of the side branch stent. And it is said that it's better to cross proximally to the side branch to avoid crossing outside the stent at the level of the carina. So this is probably what I will do. And I presume in this situation, hydrophilic wire will be the best.
Choice PT.
That's not my practice, so
Proximal, find out proximal part of ostium. I hope so. However, I don't know. So we're gonna try that. Usually, in my personal preference, is the
Hydrophilic choice PT wire.
right choice PT, hydrophilic. You're gonna make it a little more easier
Dr. Park,
passing through. Yep.
I found only a small part of incomplete apposition at the 2 o'clock to 6 o'clock in the proximal part.
That's great.
maybe it's a good reason to perform a pot with a 4-0.
Yeah, I think so.
Okay. You want to do that.
Could you
And
check?
also, if you easily walk to side range walk, we have to do the kissing balloon inflation,
Okay.
And so we're gonna do overlapping 2 stents for the
Yeah.
proximal part. You're gonna treat them at the
Yeah.
times. And so, and to be honest, in the clinical endpoint, I don't too much worry about 1 or 2 segment malpositions would be related to any clinical outcomes. However, it works. Inevitably, finally, we have to do final kissing balloon inflation, right? So proximal part manage, usually it's okay. And so, however, wire doesn't work, I will try the part, the more bigger balloon inflation. Test, please.
I find this angle because still not truly separate the bifurcation, so you really don't know where that's exactly takeoff side. But I can see this is choice PT, right? It's already passed through the same shroud. But true bifurcation by this angle is difficult to see it. How often you probably difficult to pass, and you need a crusade double lumen microcaster to assist in ASAN experience.
What do you think?
Less than 1%.
1%.
Very rare.
So you have good technique.
We didn't use too much, right? Just passing through. Sometimes it's very difficult to pass the balloon, and so we're going to use some. Okay. It will take time. It will take time, and so I don't push too much. Just rotate a little bit. I don't. Okay. There is another, disadvantage of hydrophilic. HSPT wire is too flexible sometimes. Okay, test. Okay, I'm pushing through. It will take a time. I don't want to push too much.
Okay. Good.
A little further. Okay.
Good.
It's just like CTO something. So we're gonna wait for a while. Test, please.
Test it.
Okay, good. I think it's good, right?
Good.
So, what is the lowest one? 125?
Yes. 1.2.
Okay. The reason why is the wire,
not easy to pass.
Too easy to pass, and so I want to start with a very small balloon first. And this is 125?
Yes. 1.2.
1.2. Okay, this is smallest one.
No, 1.0 is the smallest one.
Oh. Okay, I don't want to push too much. So I want to see what's happening. Central duct?
Central duct.
Okay. All
Okay.
right. It works.
Okay.
Okay, the central dot is placed the austere part of diagonal branches. Diagonal stented area. Okay, why not?
16.
Inflate. Okay, good. 1.4. 1.2. Still some resistance. Okay, why not? Inflate. More.
16.
1.4.
18.
1.4.
Yeah.
1.4. Okay, deflate. I want to have a 1.5, one more. All right, it's more. I want a stable procedures. It's a gradual dilation, and finally, I want to use the 275 non-compliant balloon. The reason why the reference vessel of a diagonal branch is quite enough to, almost 3. So.
Dr. Park,
Yep.
are you never using the decay crush, which is supposed to solve the problem of reaccessing to the side branch?
Sometimes.
No.
Only one indication for decay cross is a very calcified side branch ostium.
So, and to be honest, we have some, registry data. Lubat, you may not agree about that. However, different stent technique, including the gullet, mini crochet, TK crochets, I don't believe too much, difference. Immediate outcomes, I don't know. So, however, I don't believe too much about the clinical relevance, clinical outcome difference. So, in any bifurcation regions, operators are familiar with, okay, it's quite easy. Okay, inflate.
I agree with this.
16.
Okay, inflate. Is size-wise 1.5?
Yes.
Okay, one more.
16.
Okay, good enough. So we use the 275, the non-compliant balloon for side branches, and for the LEDs, we have already used the 35
Okay.
non-compliant,
Yes.
so we're going to use the used one, right, to save the money.
275.
So I want to try the
LED 3.5.
diagonal branch first, 275. It's more easier, do the procedures with the large guiding casters. So the reason why, in sometimes, unexpected event is more easier to handle. So 8 French guiders for especially two stent procedures. Okay, this is 275. 275 non-compliant for
Good.
diagonal branches and 35
Yes.
use balloon for
LAD.
LAD.
So for this kind of step, you would do alternative high pressure, then
Yep,
simultaneous. Okay.
exactly. We're gonna do a sequential, high pressure inflation, and then finally casing balloon inflation. Actually, the proximal LAD is big enough to negotiate two balloon, I believe so. This is LAD here.
Yes. This is
And
diagonal.
diagonal branches first, diagonal balloon a little bit out, and why not? Right. Inflate. 16, 18.
18.
I want to use the 20 atmosphere. Okay. Inflate. 떨어져 오시죠. And LAD again. LAD. 18.
35.
Okay, we have already confirmed deflate. So just, all right, reconfirm the LAD side. And then, Akasaka, you worry about the proximal part of a model position here. And so we're going to do two balloon overlapping like this. However, distal part of a diagonal balloon is anchoring the diagonal branch here and inflate. The
10,
8.
10.
Six quite enough, right? Balloon size is big. All right, 6 atmosphere in both balloon
Yes.
and deflate.
1, 2, 3.
Okay, good, perfect. So, all right, very much. Contrast, please. Even after two balloon inside, you can make a good angiogram, right? So, okay, so almost we've done so what you can do for particular this two stent technique, and so I removed the whole, balloon, non-compliant balloon system, and take a picture first. Okay. What do you think?
Very nice.
We check with Ivis.
All right, I'll do the check for the ibis. Angiographically, I think it's almost perfect. The diagonal branches, first, 275,
This is diagonal branch. Yeah.
high pressure inflation. All right.
So
we
any
do-
IBIS data regarding this kind of non-Neffman bifurcation regarding, for example, you want to achieve minimal stent area for how much for the diagonal you feel satisfied?
No.
You don't have the data?
No. So in a case of LAD diagonal branches or OM branch, obtuse marginal circumflex branch, bifurcation, actually there is not a big deal in our lab anyway. So, but I'm sorry. So the reason why, however, when you use a two stent, in almost all cases, just like high pressure, the effective stent area compared to the balloon diameters, that's the clinical outcome. Exactly no difference between the single stent,
and
optional
two
T stent, and two stent technique. We have lots of data. So Dr. Park will give us some data about the recent temporal trend changes in the bifurcation
Yes.
interventions.
Oh, this is LAD.
LAD first.
Yeah.
You mentioned LAD, right?
Yes.
All right, LAD first. Okay, this is LAD.
Yeah.
All right, we are focused on just the matter position area, the proximal part.
Distal
Distal
landing
landing
is good.
That's great. I like that, right? And some part, you mean? All right, there may be some,
Side branch, I think.
I don't. worry. 3.5, almost 4.
Yeah.
Stent diameter, so distally. Still, maybe we're gonna find out some crushed area from where it is. Okay, almost there.
Okay, 12.
All right, exactly 12 o'clock.
Yeah.
Right, and not coronas, we cannot see that. Some proximal part, malopposed area. Akasaka, you mentioned about the 9 o'clock something?
It's okay now.
All right. Two balloon, right? Bigger balloon inflation. So,
Very nice.
okay. All right, so we're going to show in the diagonal branches. You have two diagonal.
Yes.
Diagonal.
And Dr. Bob,
Yep.
this is Dr. Bae from Daejeon.
Oh, Chango.
Yeah.
Dr. Bae.
Yes.
Oh,
You really show us very nice non-left main bifurcation lesion. And you show us the 1.25 and 1.5 balloon to enhance the bigger balloon delivery. But if we have to use only two balloons because of Korean insurance system, so we have to use only two balloons. What kind of technique or what kind of tip is useful to deliver bigger size balloon without 1.5 or 1.25 balloon?
We mainly use anchoring. Anchoring the balloon for into the LED. However, I don't want to make some damage to the any. It's not a damage. However, anyways, if you can do, the balloon smoothly crossover, I will do that. So the reason why, okay, this is diagonal. We choose the 275. Okay, I want to show the distal part. Okay, here we are. All right, perfect. Almost the 3.0
Yeah.
vessel. We deploy the 275. We cannot, imagine so just the angiographic findings. However, it's good. 2.0 something.
2.5 here.
2.5. Standing at a 5 millimeter scale. And getting bigger.
Yes.
We did the high pressure inflation to 7.5. And so almost, okay, not yet. Ostial part here, encircling the well, expanded stent, longitudinal LED, right? So I think imaging concern is almost perfect, right? And this is proximal area. And then I want to pull the out. Oh, right. Oh, this is just. And wire too. And then take a final shot. Contrast, please. Okay, good. Okay, I'll take a picture here.
Yeah.
Shot. And to be honest, I like it a high, cranial and aerial. Actually, this view clearly separate with the proximal, diagonal branch from the LED like this. All right. I like this view, right? So usually okay. I think this is final.
Yeah.
If we want to do this kind of, two stent technique from the beginning, obvious guided, we're going to choose the little bit bigger stent size, the 2.75, 35, up to, high pressure dilations. That can make a big, stent area.
Yeah.
The reason why, current status, right?
Yeah.
You got some lots of data over there. Current status, bifurcation strategy cannot, differentiate with a single stent and just a two stent technique.
Okay, it's one of the questions regarding different companies' metallic DS. Do you think any difference compared with this kind of bifurcation? You didn't tell us what kind of stent you are using.
Everyone say no.
So I'm just curious because you might compare different
Right.
currently available.
In terms of, for the generous sponsorship, so we have to, we cannot say anything, right? And
We have some comparison data, real world. There's a lot of the Resolute, the Promus, Giants, and Osiros. Some of the stands for clinical outcome was nearly same, regardless of some type, CTO, bifurcation, left main. I think it's a real world. You can choose any type of.
In side branch passing, is some standards are difficult, some standards easier?
no, I don't believe. Look at this. It's marketing point.
Yeah,
It's a different company. All right, side branches, lumen wise, is ours bigger than the others. However, totally.
We are very fair.
I don't believe.
We are very fair.
Okay. All right. I hope really you all enjoy our TCTAP and our live demonstration. I really thank you for you all for joining us despite of a little bit complicated and political situation. So thank you again. You're going to make a more, wonderful meeting in the next years. And so thank you. Right.
Thank you.
That is our-
Appreciate. Thank you.
Okay, thank you very much. Thank you very much.
Thank you.
Great demonstration.
Thank you.
So we have many time. We have to move to next lecture session. So the first speaker is Dr. Cohen. He is going to talk about what is the optimal duration of Dapt after PCI and DES. Cohen not here. So we have to discuss so many time.
If I ask Dr. Laborde, if you're going to do this case radial, and what will be your approach? You're going to use 6 French guide catheter or 7? Are you going to use this kind of technique?
In our group now, we have 10 operators, and none of these operators is doing more than 5% femoral. So, our rate of transradial approach for PCIs is 95. Mine is close to 98. So, with this, you can imagine that the only one I'm not doing radially are the one where the radial is too small or occluded for a previous procedure. So, you just have to adapt your strategy to the radial. It was said by Dr. Wu, we can certainly do this procedure with 6 French. So if we can do with 6 French, there is no reason not to do from the radial. And we are doing the same for the left main. We have big series. We did 800 during the last 4 years, and I think a great majority of them were done from the radial. And we are also using the radial for CTO and for sometimes frequently double radial for CTO. So it took a long time to adapt when I began in 94, I began radial in 93, in 95 I have 50%. So to come from 50% to more than 95 now, it took 20 years. So it was done because we have experience. We have developed a specific technique to put the catheter in from the wrist to the aorta, and also the material has changed a lot. And now we can. I was just testing a few days ago a new schistless from Cordis, very interesting. So I cannot say anymore. But okay, we can do now quickly and easily 6 French schistless from the radial, no problem.
But sometimes old age is very tortuous subclavian.
Yes, it's less tortuous from the left. So, but between left and right radial, the difference is when you are young there is nearly no difference. But when you are not young, then you have to look at your morphology. So you have morphology of operator for right radial, me, for example, and you are very tall and thin young people that can still perform from the left radial. So the right radial for me is very clearly my preference. Even if we see left subclavian sinuosities than in the left than in the right.
We don't care about the age. For example, 80 years old female.
Yeah, we do expertise of coronary angiography expertise before TAVI last week 99 from the right radial.
What about you?
We actually, in my lab, we have right-handed dominance and left radial dominance operator. So it doesn't matter for me. It's only about maybe left radial probably increase somewhat radiation. So we have to negotiate. But right now I'm kind of modified with Dr. Kimenage. He's moving the patient's hand on top of his groins, and we can puncture from there, so become a slender and slender. So we even started to do a snap box, a 5 French, slender, and Swiss we can go from there. So it's even more patients, more comfortable. And I'm quite used to use bilateral radio to do CTO intervention. But in our series, retrograde has been accumulated more than 500 cases. I don't see that the supported strength is less than the bilateral femoral approach. So this is our unique bilateral radio approach.
Dr. Cohen, I think, is here.
Okay, Dr. Cohen, go for lecture. You're waiting for you.
Waiting for you.
That's why we have a discussion.
Glad I was early. Thank you. Maybe I can talk slower. So the topic I've been assigned for this lecture is the optimum duration of DAPT after drug-eluting stents. An impossible question to answer, but I will do my best. These are my disclosures. So if we think about the history of DAPT after PCI and stenting, when stents were first introduced in the early 1990s, bare metal stents were approved and we didn't use any DAPT, just aspirin and warfarin, and patients bled a lot. And then in the late 1990s, the ESAR trial first and then the STARS trial next showed us that the use of dual antiplatelet therapy, in this case with ticlopidine and aspirin, improved outcomes, and this was given for 1 month, partly because it was bare metal stents, partly because of the toxicity of ticlopidine. In the early 2000s, drug-eluting stents were first introduced, and the sirolimus-eluting stent was recommended for 3 months, and the Taxus stent for 6 months of dual antiplatelet therapy, and that stayed for about 3 or 4 years until we had the drug-eluting stent firestorm in the, around 2006, 2007, where it was recognized that we were starting to have these late stent thrombosis events, and the duration of dual antiplatelet therapy was increased to 12 months minimum, with longer for many patients. And that persisted for another 6 or 7 years until we had a number of trials, including the Dapt trial and others. And now the recommendation is to individualize, which is sort of like saying nothing. So let's just look at some of the data here and try to understand what the data tell us. So there have been at least 11 randomized trials of DAPT duration after stenting, and they're kind of nicely summarized in this diagram that I stole from Greg Stone, where you can look and see at the different durations that were being compared. So we have some studies that are comparing a very short to 12 months. We have studies that are comparing 6 months to 24 months. We have studies comparing 12 months to even longer. We have a whole range of different studies, and Dr. Palmerini and colleagues have done us a nice job of summarizing all these things and putting them into a meta-analysis. And there are some basic concepts that come out of these meta-analyses. If we look at long-term versus short-term DAPT with respect to AMI, very clearly favors long-term. About a halving of the risk of AMI with long-term DAPT as compared to short-term DAPT. What about stent thrombosis? Same story. Again, about a halving the risk of stent thrombosis with longer-term DAPT rather than shorter-term DAPT consistently across all the trials. Why it's not an easy decision, though, for us is this, which is that long-term DAPT consistently increases bleeding, which is fairly intuitive given the mechanism of action of enhancing antithrombotic therapy. So we have a clear situation where we have trade-offs. We have clear reductions in stent thrombosis, clear reductions in myocardial infarction, increases in bleeding, and negligible effects on mortality. In fact, some studies would suggest an increase in mortality. So I want to talk about 3 issues with respect to Dapt duration. I want to talk about whether the stent type matters because we have different types of stents. We even have BRS these days. I want to talk about whether 30 months is enough if you're going to give long-term, or is there a suggestion we should give even longer data. And then I want to spend the bulk of my time talking about how we ought to individualize care because that's what we have to do when we have trade-offs. So does the type of stent matter? Well, the answer here is yes and no. These are data from the DAPT trial, which is the one trial that included the most different types of stents. It included first generation, second, and even third generation drug-eluting stents. About half the stents in the trial were current generation everolimus-eluting stents. And what you can see is, if you look at the relative risk reductions as summarized on this forest plot with respect to stent thrombosis, consistent relative risk reductions across the different stent types. But relative risk reduction doesn't really tell the whole story. You need to look at absolute risk reduction because we are making trade-offs. And in the overall population, the absolute risk reduction was about 1%, meaning a number needed to treat of 100 with long-term DAPT in order to reduce a stent thrombosis event. However, with the most contemporary type of drug-eluting stent, the stent thrombosis rate is about halved. The number needed to treat is about 2.5-fold increased. And so stent thrombosis really does matter with respect to the stent type. Now, why I says it doesn't necessarily matter, though, is a lot of the benefit of drug-eluting stents, of long-term DAPT, do not relate to the stent whatsoever. So again, this is data from the Dapt trial, looking at myocardial infarction rates with short-term DAPT shown in the blue, long-term DAPT out to 30 months shown in the green, and what you can see here, again, a very impressive risk reduction, about a 40% risk reduction. But what is key to recognize is that 55% of the benefit of myocardial infarction reduction with prolonged DAPT in this trial wasn't related to stent thrombosis whatsoever. It was related to disease in other vessels. So the stent matters for preventing stent thrombosis. The more recent drug-eluting stents that we have are more protective, and you don't need as much DAPT. On the other hand, all the other vessels don't know about the stent that's in your LAD or in your diagonal, and for those, the duration of dual antiplatelet therapy really doesn't depend whatsoever on the type of stent. So it really does, I think actually the type of stent matters less than we think. Is 30 months enough? That's an interesting question, and again, I think the DAPT investigators, and Laura Morey and Bobby Ye, were very clever in the way they designed that trial, because in addition to testing whether 12 months or 30 months of DAPT was beneficial, the trial included this very interesting time period after the study treatment was stopped to continue to follow the patients to see what happened when you stopped DAPT at the end of 30 months. So here is stent thrombosis, a nice risk reduction of about 70% in stent thrombosis with prolonged DAPT. When you come off the DAPT, there's a little convergence of the curves. The curves start to come together, suggesting that there was continued benefit and 30 months may not be enough. That effect is even more striking when we look at the composite endpoint of major adverse cardiac and cerebrovascular events. Again, about a 29% relative risk reduction from month 12 to month 30. You stop the DAPT and the curves start coming back together. So this certainly strongly suggests that if we want to really maximize the benefit from DAPT in a patient who can tolerate it, that 30 months isn't the answer. It may well be lifetime or certainly longer than 30 months of therapy. But I want to finish up talking about this very challenging issue, which is based on the available data, given the trade-off between bleeding and ischemic event prevention, how are we going to individualize care? Because that really is the key for us. Now, of course, that's why we're physicians. We do individualized care every single day for every single one of our patients, but it isn't really a very quantitative or satisfying statement to say, well, just use your intuition, because our intuitions aren't always the best. Now, one way to do it, which has been advocated again by Tullio Palmerini and Greg Stone in this review article that they wrote last year in the European Heart Journal, is they said, well, let's just separate the groups and we can identify patients who are at high bleeding risk, patients who have bleeding diatheses, who are on chronic anticoagulation, who have chronic liver disease, who have had a previous history of bleeding on DAPT. These are high bleeding risk patients. There we want to shorten the Dapt. We want to give 3 to 6 months. Then we have low ischemic risk patients, stable coronary disease, single vessel disease, simple stenting. Here again, the risk, presumably of stent thrombosis or of recurrent events because they have relatively simple disease is not that great, and you want to go just with short-term DAPT. Intermediate ischemic risk, they say troponin positive ACS, maybe a year, and then high ischemic risk, high-risk ACS, prior MI, diabetes, renal dysfunction, complex multivessel CAD, favors greater than 1 year. Well, this is a nice scenario. It's a nice way of looking at things, but unfortunately, in real life, our patients don't fit cleanly into any one of these buckets. You may have a patient who has a history of bleeding diathesis, but presents with a high-risk ACS, or a patient with stable coronary disease that you have complex multivessel revascularization in. So there isn't necessarily, each patient fits cleanly into each of these different buckets. And for that reason, my personal belief is we need to use risk scores, we need to use quantitative methods in order to estimate who's going to benefit and who's going to be harmed by long-term DAPT. Now, one approach that has been used and one that I've been very involved in is the Dapt score. It's actually a fairly simple construct. It's, people say, well, this is complicated. I don't think it's that complicated. If you can't do the math in your head or on a piece of paper, you can go to the website and do it very, very easily in about 30 seconds for any one of your patients. But these are the characteristics that go into the DAPT score: age, diabetes, smoking, prior PCI, reduced LV function, and then a couple of procedural characteristics, whether the patient was an ACS or an MI at the time of presentation, whether the intervention was on a vein graft or a small vessel. And you can see the range of scores ranges from -2 all the way up to 10. The median is right between 1 and 2, and that really is the key point to remember. 2 and above is above the median. That's the group of patients that benefits from long-term DAPT. Less than 2 on the score are the patients who are harmed by long-term DAPT. And you can see that very clearly in these data. So if one looks at stent thrombosis, and you categorize the patients by the quartile of the Dapt score, so here are the patients who are less than 2, here is 2, and here is greater than 2. Significant reductions in stent thrombosis by extending DAPT in the patients with Dapt scores of 2 or greater. Even more significant reductions in myocardial infarction by extending DAPT in patients with Dapt scores that are 2 or greater. And if you're worried about the bleeding, well, in the highest 2 quartiles, again, of the Dapt score, very little excess of bleeding whatsoever. So it seems fairly clear, based on these data, that this is an approach that we can use for many of our patients. Now, it doesn't apply to all of our patients. It only applies to the kind of patients who are in the Dapt trial. So it doesn't apply to patients who have a history of prior bleeding. It doesn't apply to patients who are on chronic anticoagulation. And it doesn't apply to help us make decisions for the first year, because this is all about decisions beyond the first year. So how do we make decisions in the first year about who needs to be shortened? Well, that's where this risk score, which was really just published last month in The Lancet, comes into play. And it's really a very elegant risk score. I urge you to take a look at this paper, take a look at the website. Again, it's pretty easy to do if you use the website. But this is a score that was developed by Marco Valgomili and his group. They pooled data from 8 multi-center randomized trials of varying Dapt duration. And the score predicts the 1-year bleeding risk on DAPT. So it tells you approximately what risk this patient has if they take DAPT for a year of having a major clinical bleed, either a TIMI major or minor bleed. And the score is based on characteristics you can identify right at the time when you do the PCI. You don't have to wait till a year afterwards to assess it. What does the score look like? Well, here are the 5 characteristics that go into the score: the hemoglobin at the time of the procedure, their age, whether they have a history of prior major bleeding, their white blood cell count, and their creatinine clearance. That's it. Pretty simple. You can go to the website, it's right here, and log in there and enter this information, and it will give you a score, and it will give you a quartile. And what you can see is as that score increases, this blue curve here is the risk of TIMI major or minor bleeding, which are all very important bleeds, and you can see that in this top quartile, a score of greater than 25 correlates with a high risk of bleeding, basically a risk of bleeding of 2 to 4% over a year on DAPT. So that's a group of patients where there certainly is reason to believe that shortening the DAPT may make good sense. What's really interesting, though, is that when you apply this bleeding risk score to patients in those trials or to other patients, it not only predicts the bleeding risk, but again, it predicts the net clinical benefit. And you can see that here by looking at the ranging from the lowest quartile of that precise bleeding risk score to the highest quartile. And then here, this dark curve is the predicted net clinical benefit. And you can see that it is positive. It is a net clinical benefit, greater reductions in ischemic events than increases in bleeds, all the way up through that 3rd quartile. And only in the 4th quartile do you start to see harm. And so again, I think that this bleeding risk score, which is a brand new score, but is fairly easy to apply, may be very, very helpful in identifying particularly the patients in whom we want to give short-term DAPT after drug-eluting stents, like 6 months or even down to 3 months in some cases. And this can be used, again, to decide things like what type of stent you're going to use. If the patient has a very, very high precise bleeding risk score, maybe you want to use a stent that you're very comfortable, you can shorten the DAPT. Maybe you're going to use the BioFreedom stent without a polymer that we know is effective with just 1 month of dual antiplatelet therapy. Probably you don't want to use an absorbed BVS, where we think that probably even longer-term DAPT is necessary. So again, I think a very, very useful score to have at your fingertips, and something you want to probably include on your saved list of websites. So to conclude, I don't have a single answer to the question of how long we should give DAPT after drug-eluting stents. I would say that for most patients who undergo PCI with our current generation, excellent drug-eluting stents, 6 to 12 months, the amount we've been giving really for the last few years, represents a reasonable balance between safety and efficacy, and this is currently reflected in the guidelines. For selected patients who are at very high risk of bleeding, patients on oral anticoagulants, patients with a history of prior bleeding, or patients with that precise risk score that is over 25 in the top quartile, I think shorter-term durations of DAPT are likely sufficient, and you want to choose a stent that can support those short durations of DAPT. On the other hand, for patients who present with an acute coronary syndrome, especially acute myocardial infarction, and have additional risk factors for recurrent events as reflected in the DAPT score, longer-term therapy, and in this case I mean more than 2 years, should be strongly considered as long as the bleeding risk is not excessive. I think that's a key thing, is we still have to balance that against the bleeding risk. And finally, I would definitely advocate that both the DAPT and the precise risk scores appear to be useful tools for identifying patients who should be treated with shorter or longer-term DAPT. Thank you very much.
Thank you very much. Any comment from the?
One question, David. Is chronic AF for PCI, what do you think is your recommendation?
Well, that clearly, chronic AF, certainly with a CHA2DS2-VASc score of 2 or greater, needs oral anticoagulants. And oral anticoagulants plus DAPT is a very bad mix. And so my current feeling is that we have reasonable data, certainly with warfarin and short-term DAPT, the West regimen, that we should make the duration of triple therapy as short as possible, no longer than a month. Remember, the West trial itself used no triple therapy, just double therapy, just clopidogrel and warfarin. We recently just had the Pioneer AF trial with rivaroxaban, which also showed that you can achieve similar reductions with a slightly reduced dose of rivaroxaban, 15 milligrams a day, plus, again, single antiplatelet therapy. So I think with chronic AF, we're probably never going to have the perfect trials. There still are more going on. But the predominant evidence, and I think our guidelines today say, as little DAPT as possible in that setting. And again, that may be the perfect place for some of these newer stents that are specifically developed, again, like the BioFreedom, where it clearly can be used with 1 month of DAPT.
Precise risk score include WBC count. How can you explain this WBC is a risk factor of bleeding complication?
How can I explain it? I guess it came from the computer, but and I didn't do it. But I mean, what would be a possible explanation? I suppose it's a marker of inflammation, and inflammation is associated with thrombosis. I think if we have to, but I long ago learned that we shouldn't try to necessarily tell a good story. Just the data are the data. We should pay attention to the data, but telling the story that's what I do to my kids at night, I think.
Hemoglobin is understandable, but WBC is...
Yeah, no, it is a funny one that's in there. I think, again, the nice thing about the DAPT score is you can calculate it at the bedside. You can just have a little card. You can calculate it very, very easily. The precise score, you have to go to, because it has continuous variables in it, you have to go online to use their calculator. But I've gone online, I've tried it, it's pretty easy to do.
Do you know what's the C-statistics for the Dapt?
A great question. So the C-statistics for both of those bleeding scores are in the range of 0.65 to 0.67. And that's not the kind of C-statistics we like to see. We like to, because that means that the discrimination is not great. It means that if I say your Dapt score is high, that yes, you are more likely to have an ischemic complication than a bleeding complication, but I wouldn't bet my house on it. But that is very common for long-term risk scores. That's the same range as the C-statistic for the CHA2DS2-VASc score, the HAS-blood score, other scores that we use all the time. So, while it would be nice to have a perfect crystal ball that had a C-statistic of 1, I think we're going to have to live with these imperfect things. They improve our prediction, but they are not perfect.
Thank you, Dr. Cohen. We'll move to the next lecture, the last lecture. by David Holmes, dedicated to LA occlusion for stroke prevention. What is the ideal?
It's a great pleasure to be here. And some of the answers in terms of triple therapy may be indeed found in this talk as it relates to an approach in those patients who are going to need to have an anticoagulant. It's an interesting talk title to talk about what is ideal. So I'm going to talk about left atrial appendage occlusion and maybe what is ideal. There's a relationship in terms of Mayo has a financial interest related to this. It's an old financial interest, but that needs to be declared. What do we have? If we don't have anything that's ideal, and we'll talk about that, what is it that we have? Well, we have a huge and growing problem of patients with atrial fibrillation, some of whom are going to need dual antiplatelet therapy, some of whom won't. Increased risk of stroke and systemic embolism in that group of patients who have non-valvular atrial fibrillation. Number two, we know the proximate pathophysiology. Number three, we know that there are alternative medical treatments, but they have significant limitations. And finally, we have alternative strategies to medical therapy, but they also have significant limitations. Is it an issue? It's an issue no matter where you live. This is the worldwide prevalence, at least what has been published, what information that's available. And you can see that around the world there are pockets of people and pockets of populations that have increased frequency of atrial fibrillation. The rest of the world, we just haven't measured it because they're no different than anybody else. And atrial fibrillation then is a global problem. You might say we have solved that already. You might say we've got anticoagulation that has been used and tested in about 100,000 patients. And so why would you need something that was ideal to treat the left atrial appendage with if you already have anticoagulation? The issue is that the bleeding rates are not inconsequential. They're 2 to 3%. Discontinuation rates are 20 to 25%. Any bleeding is 15 to 25%. Whether you use the PRECISE score or any other score, bleeding is an inherent complication with anticoagulation. You might say in this area of the world and in every other area of the world, the new oral anticoagulants have solved the problem. And there are many people that would in fact believe that. Except this is an incredibly important study that was just published this last year. It was in about 75,000 patients. Patients who were at risk with non-valvular atrial fibrillation who were given NOAC or who were given warfarin. And they looked then at a year period of time, as you can see here, a median of 1 year period of time. So you saw the patient and said, I've got a new drug that's going to be great for you. At the end of a year, if you were to look at those patients in whom you had written a prescription for apixaban, about 50% of the patients were on apixaban. The rest had said, no thanks. If you had given them a prescription for dabigatran, it was about 50%. If you had given them a prescription for rivaroxaban, it was about 50%. All NOACs are 50%. And so you need to realize in your practice, if you say to the patient, I've got the perfect drug for you, this is the prescription, every other patient is going to fill that prescription. Just even fill it, let alone take it. So it's a huge deal in terms of how we do stroke prevention in patients with non-valvular atrial fibrillation. This is the proximate cause of stroke in the setting of non-valvular atrial fibrillation. It's a left atrial thrombus that is initially at home in the left atrial appendage, and then sometime later, just a short time later, in this particular study, it's no longer at home, it's gone off to play. It's gone off to play, and that then is the proximate cause of stroke in the setting of non-valvular atrial fibrillation. What do we have? We're going to talk about ideal things. Let's talk about real-world things. We have 3 different groups of devices. We have an endocardial plug. It's like the Watchman device or the Amplatzer cardiac plug or the Wavecrest. We have epicardial loops. And we have then hybrid systems like the lariat system, where there's a transeptal sheath and then an epicardial sheath. So we have different approaches for the use to prevent stroke in the setting of non-valvular atrial fibrillation. What's the data that we have to see whether it's really good or it's sort of good or maybe not so good? This is the information from the Watchman device. It's only one of 2 randomized clinical trials in the field. It's a patient-level meta-analysis of looking at the Watchman device versus warfarin. That was the data that we have. Efficacy is about the same. All stroke or systemic embolism is about the same. But the major difference is a reduction in hemorrhagic stroke in patients who are treated with the Watchman device. You also might look at this bottom 2 columns. The cardiovascular or unexplained death is 50% reduced in the group of patients who get the Watchman device. That has been seen repeatedly. There is a reduction in mortality. Whether that relates to the fact that patients on anticoagulation bleed more, I do not know the answer to that. But that's the information available. Placement of a device in these high-risk patients, there's a 50% reduction in mortality. And there's an 80% reduction in hemorrhagic stroke. And that's the information that we have. How does that compare with reduction in mortality with dabigatran, either at 110 or 150, or rivaroxaban or apixaban? We can see that the mortality reduction versus these other agents swamps them all. It's dramatically better than the mortality reduction that is seen in patients who are treated with either warfarin or with the new oral anticoagulations. That is, again, the information that we have. You might then say, well, if these devices are really good, they should be 100% successful. They're not. 100%. They're not. This is the data, at least in the Watchman device. We can see this was the very first trial, 90% success rate. Following FDA approval in the United States, it's about 96%. In Europe, it's about 99%, 98%. It's not perfect. It's pretty good. We're still not perfect in this regard, but we do have a device that indeed works and is associated with a reduction in hemorrhagic stroke and cardiovascular mortality. You might say, well, how often does the wheel come off the car? How often is there a huge complication? And this is a complicated slide. Let's just look at the far right, and we can see the different trials from PROTECT to post-approval and evolution, the aggregate data. Pericardial tamponade is 1.28%, not 0. It's 1.28%. It's much better than it used to be. Procedure-related stroke is 0.18%. That's the information that's available. Procedure-related mortality is 0.06%. So we now have a device that, while it is not perfect, looks like it is safer and safer and safer. You might say, well, what patients really want to do is to get off oral anticoagulants. There are 2 groups of patients in terms of long-term anticoagulation. There are the 50% of the patients that don't take it anyway. In the 50% of patients that are taking it, they'd still really like to get off of it. And in that 50% patient group that are taking it, 99% can be off of it. So at the end of a year, the majority of patients can be off anticoagulation. What about the rest of the world? What do we know about the rest of the world? The rest of the world, at least from the standpoint of the United States, the rest of the world looks better and better and better and better in our awful political scenario that we're facing. But anyway, this is the rest of the world. This is the evolution trial. It's a trial that comes out of Europe, multi-center registry of more than 1,000 patients that looked at what the Watchman device performs, how it performs in the rest of the world. And this is what they found in the group of 1,021 patients, in whom 72% were contraindicated in terms of anticoagulation. At 3 months, we can see that despite the fact that they did not use anticoagulation post-procedure, the event rates were very, very small. We can see that strokes were 0.4%. There were 4 strokes. Bleeding was not perfect. It was 4%. Device embolization was 4.4%. There were 4 events, and so that you can see that in the rest of the world, this technology looks like it's incredibly safe, even in those group of patients in whom anticoagulation is contraindicated, and it is effective. You might say, well, in my country, in my center, I don't use the Watchman device. I use the Amulet device, the Amplatzer device, which is the other device that is used around the world. We can see that this is a device that looks somewhat different, but there's a large experience with that over the world. This is the information on data that was presented at TCT. 1,000 patients. This 1,000 patients, 73% had had a history of major bleeding and were not felt to be candidates for anticoagulation. And these were the major adverse events: 3 deaths, 0.3%, 3 strokes, 0.3%. The total event rate was 2.7% in a group of patients in whom they could not take anticoagulant therapy. So we now have 2 devices that look very, very good in terms of being safe and in terms of being effective. How does that compare to other studies? These are the implant success rate for the Amulet device here, the ACP registry, and the Watchman device. They work about 97 or 98% of the time. Early mortality is about 0.3 up to 0.7% in this high-risk group of patients. There are residual issues. There are the issues of variable anticoagulation strategies around the world. In terms of anticoagulation strategies, less is always better. Less is always better, provided that it is safe. We have around the world that less indeed is better because it is safe. And we will see that the majority of these patients will be able to be treated without anticoagulation. There will be the issue of residual leak, and there will be the issue of device thrombus. Both of them are important, but they are incredibly infrequent. Perhaps the most important part of this is that there are different kinds of left atrial appendages. As you look around the room, you're all different. You are all different. Not only do you have different noses, but you have different left atrial appendages. Whatever device you choose, you have to be able to fit the device for the left atrial appendage. That is true. And so what could we say in conclusion? Left atrial appendage occlusion devices have a very high technical implant success rate. It's associated with low rates of peri-procedural and early adverse events. It's associated with a marked decrease in hemorrhagic stroke and in cardiac and non-cardiac mortality. Post-procedure anticoagulation strategies vary but result in excellent outcome, and less is better. Additional long-term data is being collected. So now that I've talked about all the data that we have, what would we like to have? This is the wish list. We'd like to have something that's predictable and safe and effective for reducing ischemic and hemorrhagic strokes. We're better, not perfect. We'd like to have something that's minimally invasive and can be used in hybrid procedures. That's incredibly important. Wouldn't you like to have a device that you could use with TAVR or with MicroClip? That'd be a big deal. It's being tested, and it is a big deal. It does not require adjunctive anticoagulant therapy. We have that. Can be delivered by cardiology and EP and cardiovascular surgery. And we have those technologies, those approaches. And so we've been able to achieve that. Can be used to treat a variety of left atrial appendage sizes and shapes. We're working on that. It is not perfect, and we want something that is stable, heals fully and completely without any residual leaks. And that is works in progress. How long is it going to be before we have the ideal device? Patience. Patience. It's coming. Thank you.
Any question for David Holmes?
What's the guideline status for the recommendation of this now?
Pardon?
The guidelines, what the guidelines say about the recommendation of Watchman or the devices now?
With the guidance?
Guidelines, yes.
Oh, the guidelines. Depends upon whether you live in Europe or whether you live in the United States. In Europe, it can be used and is approved in patients who either cannot take anticoagulation or who can take anticoagulation. In the United States, at the present time, the guidance says you have to be able to take short-term anticoagulation for 6 weeks, but you as a physician or the patient doesn't want to be on anticoagulation for longer than that. So those are two very different guidelines. I think that we will move undoubtedly more towards the European approach, where we will use it in patients who can take short-term anticoagulation if you need to heal the device, or those patients in whom they cannot take short or long-term anticoagulation.
So is that 2A or 2B?
It's a 2, at the present time it's a 2B.
So majority are against it.
Depends on who you talk to. No, that's terribly true. Those people that are, that is true.
Any other question from the audience? Okay, thank you, David Holmes. I think this is the end of the session, and it was nice to be there with you. Thank you.